Good afternoon, everybody. Welcome to the Healthcare Financing session of the AHBS second webinar series brought to you by Africa Health Business. My name is Nishit Shah, Director and Co-founder of AHB. Before we start the webinar, I would like to take you through some housekeeping rules. Attendees will be on mute during this session. This webinar will be held in English. If you would like to listen to the session in French, please click on the translation button on your screens and mute the original audio. This is a 90-minute session. You can post your questions in the Q&A section on your screen, and your typed questions will be responded to as much as possible. Throughout the webinar, there will be pop-up questions, and we kindly request you to answer these. Finally, we encourage you to tweet about the webinar using our hashtag AHBS2020. I would also like to take this opportunity to introduce you to Africa Health Business, the organizer of today's session. AHB is a Pan-African consultancy, advisory, and investment firm. Our team of specialists provide a wide range of services aimed at supporting and promoting the growth of the private health sector in Africa with the overall aim of improving access to affordable, quality healthcare on the continent. On this slide, you see the agenda for today's session on healthcare financing, which will run for 90 minutes. While the COVID-19 pandemic has exerted significant strain on already overstretched health systems across the region, further affecting the delivery of other essential health services, a broader spectrum of stakeholders is now feeling the consequences of chronic underinvestment. The impact of the pandemic has demonstrated that every sector is dependent on the health system. The rising prominence of this sector has presented us with a unique opportunity to increase investment in health. To meet this growing need, almost 30 billion US dollars in new investments is required within the sector. In 2019, private equity investments in healthcare around the globe amounted to 78.9 billion US dollars, of which only 0.2% was invested in Africa. The total private equity investments across all sectors in Africa amounted to $3.8 billion, of which 4% was represented in healthcare. 52% of the healthcare services in Africa are being provided by the private sector, which is a clear indicator of a thriving industry. The pandemic has given rise to even more opportunities in healthcare markets across the continent through the rapid adoption of digital health solutions, increase in local manufacturing to meet local needs, and innovations around supply chain management to curb the global disruptions that we have encountered. To deep dive into the session, we have an exciting lineup of speakers, and I would like to introduce you to today's moderator, Dr. Amit N. Thakur, Chairman of Africa Health Business. Before I hand over to him, here is a short clip from one of our event sponsors, the Medtronic Foundation.
Medtronic Labs is built upon 5 principles. First, we design with and for the communities to address local barriers across the care continuum. Second, we employ evidence-based practices and protocols for uncompromised clinical excellence. Third, we address the social determinants at the root of poor health. Fourth, we integrate digital and product technologies for high-tech, high-touch models of care. Fifth, we innovate operational models that enable efficiency at scale. Learn more at www.medtronic.com/Medtronic Labs.
Thank you so much. Good afternoon, good evening, and good morning, wherever you've joined in. Africa Health Business welcomes all the attendees. We've been having delegate enrollment from over 40 countries, US, UK, Asia, and lots of delegates from Africa. So wherever you've logged in from, on behalf of Africa Health Business and the panelists, I'd like to welcome you for this session. Thank you, Nishit, for setting the stage. Indeed, growing investments in healthcare is truly a topic that requires broader discussion. I'm delighted that we have three very illustrious leaders in the healthcare financing field. Joining me in this panel is Kwasi Bohane from Netherlands, who is a director of advocacy at Farm Access Foundation. Also joining us is Audrey Obara, who is the head of healthcare investments at Swedfund, and Shakir Merali, who is a partner at LGT Lightstone, very well accomplished, all three of them in their field. The format of today's discussion will be literally around conversations we will have between the panelists, and I urge all the attendees to put in their questions on the chat group, and we'll have an opportunity to answer them as we go along into this session. I would like to start with introducing our panelists and let them also speak about the trend that they see in the healthcare financing space because they're deeply involved there. So I will go in order. I'll start with Kwasi Bohane, then I'll move to Audrey Obara, and then I'll come to Shakir. Let me begin with you, Kwasi, and thank you for joining us. Kwasi, you know, is a PhD in development economics with an MA in economic geography from the University of Oxford. I have engaged with Kwasi in so many healthcare forum and conferences, as well as some projects that we've done together. He has a long history in healthcare and development, having worked at Oxfam and Hivos before joining Farm Access, a Farm Access group based in Netherlands. He's currently a director at the firm, leading the West Africa region. He's very well known in the health circles and creates strong partnerships to promote affordable care in the region. So Farm Access Group is diversified, but a lot of the work they do is in financing. So welcome, Kwasi, and just tell us a little bit about the work that you do in Farm Access and briefly what you've noticed as a trend in the financing space on the continent. Over to you, Kwasi.
Yeah, thank you, Amit, and thanks for the nice introduction. At the point I felt, hey, I would like to meet this guy that Amit is talking about. So at Farm Access, the aim is to build health systems in such a way that people who until now do not have access to care, or basically everybody, will be able to have access to care not only today, but tomorrow, the day after, so in a long-term basis. So for that reason, we have what we describe as an integrated approach, where we work on the financing of care. One of the challenges that we have in Africa is the inability to develop an inclusive system, you know, where we pool resources and risks together to finance care. So it's a critical component of the work that we do, you know, addressing the financing part of it. We've also seen that even if the financing is available, but there is no quality, people will not go for care. So we have a strong initiative on the delivery side, you know, improving the quality delivery systems. We've developed a tool or approach called Safe Care, you know, which is a stepwise manner of helping hospitals, facilities, clinics, you know, name them, to in a more systematic way improve the delivery systems. And it's also incentivize them to do that, you know, give them the tools for capacity building, monitor the performance. So we have the financing, then we have the delivery. And we realize that if you want to really embark on sound approach towards quality improvement, you need money to do that. So within Farm Access, there's an initiative called Medicare Credit Fund. And the Medicare Credit Fund does two things. One is help build the healthcare as a business. So business training, business development, and everything that goes into making sure that a provider can manage the facility or the service as business. And in addition to that, give them the financing to be able to improve upon the quality. And until now, we've disbursed quite a huge sums of money, working with local banks to the tune of over $80 million. Repayment has been great, over 96%, because of the due diligence and the capacity that we build around business development. Since 2015, what we've seen in Africa is the rise of technology, mobile technology. And you guys are in Kenya. You see how M-Pesa, Safaricom through M-Pesa has improved access to finance, financial inclusion. So using the mobile technology, we have worked together with a social enterprise called CarePay to develop in Kenya. They call it MTIBA, which links the payer, the patient, and the provider in a way that they will be able to finance and deliver healthcare. I hope you have the time to talk more about this. And then in addition to all this, we partner with research institutions, both internationally, but also in Africa, to do research into our work, with the condition that they will publish the findings in a peer-reviewed journal. So, in a nutshell, these are the things that we do. And the ultimate goal is to ensure that, everyone in Africa, irrespective of their economic situation, will be able to access healthcare. Hamid, over to you.
Thank you. I think, Kwasi, you've touched on something that's really is important, and that is quality matters. Just spending money in healthcare and building different infrastructure is not enough. So focus on quality of care in Africa is important. But you also touched on technology, and I'm sure when I'm talking to the investment champions like Audrey and Shakir, they will tell us a little bit of what they're doing. Mm-hmm. They'll also give me their version of the trend. And right in front of you, there is a poll right now. Please feel free to log on and answer it. Let me move to Audrey. Audrey is my alma mater. She studied at the University of Nairobi. She completed her actuarial science and then got a license as an ACCA. She also teaches piano, but has built a successful career path, having previously worked at Deloitte Consulting before joining Swedfund. At Swedfund, she oversees the health portfolio within the firm, and she has a very clear focus plan on expanding their footprint in Africa. So Audrey is a senior investment manager, and in my recent engagement with her, it's very clear on the kind of work that they're doing, and they'll tell us a little bit about the new portfolio and the new fund. So Audrey, over to you. Tell us a little bit about Swedfund and what you've noticed as the trend in healthcare financing. Welcome, Audrey.
Thank you, Amit. So Swedfund has invested in healthcare for many years. We've invested in Africa and Asia, and we continue to focus on these two markets. Traditionally, our investments were on the healthcare services side, so provision of healthcare in primary care, outpatient clinics, and then secondary care. And then in some countries, a bit of specialized care. In Ethiopia, cardiac care. In Egypt, brain tumor treatment. And then in Ghana, there was a cancer center. Now, as we continue to focus on that sector, we've also broadened our mandate to look at how can we continue to improve the supply chain to reduce the cost of care. And so in India, we've invested in a fund called HealthQuad that looks at early stage SMEs and venture investments in healthcare that are looking at innovative solutions, things that have not been there before. They've invested in some companies looking at supply chain for healthcare. How do you make the cost cheaper for hospitals to get good equipment? And then we've looked at a company here in Kenya recently, Kasha in Kenya and Rwanda, that provides information and products to women, because that's another side of improving care. And then we are keen to look at health tech, pharma manufacturing and distribution, both in Africa and Asia. A bit more challenging in Africa on the manufacturing side, but something we're open to looking at, and also on the side of equipment supply, with the aim of really reducing the cost of care. And then further along, we're also looking at how do we work to fund SMEs, because healthcare is fragmented in many of these countries. I think more so in West Africa than East Africa. How do you fund SMEs to provide quality of care? And Kwasi touched on some of these points. So as Swedfund, we're a small team. There's no way we can go out and do $100,000 loans. It's just not feasible. But how do we work with intermediaries? MCF could be one of them. Banks in these countries could be one of them, to reach some of these SMEs, because even as we push for consolidation, it's going to take time. As you see healthcare groups coming up, it's not something that's going to happen quickly. So as people still need to have care, we can't wait for another 10 years to put up another, hospital holdings group like we have in East Africa, in other parts. So people still have to access care. So how do we support that access to care for them, and make sure that it's also quality care? So as Swedfund, we're not looking at just investing in healthcare companies. We do want them to have quality, and safe care is one of the key accreditation programs that we've worked with in our portfolio and continue to support. For some of our portfolio companies, we have supported them either through technical assistance to get safe care accreditation, among other environmental and social governance things that we handle within our portfolio. So we look at quality, we look at environmental and social matters, and then we look at also impact, development impact, the staff, the workers, are you training them? We also look at gender. It's something from our Swedish government to work with gender in our portfolio companies. Traditionally, healthcare companies have a lot of women, so we score quite highly there. But we want to look further into that in leadership positions, and in also products for women. You'll be amazed that sometimes women are left behind, yet on the maternal side, they're the ones who bring life into the world. So those are very different areas of interest for us, all with a view of reducing the cost of care while still making sure that it's quality care and increasing access for people.
Thank you, Audrey. That was really clear. And I think you've touched on 4 key points. I'll come back later when we come to conversations. You talked about healthcare technology. You talked about pharmaceutical manufacturing. You talked about also distribution and supply chain that Nishit touched on earlier. And you talked about medical equipment. And of course, all the aspects around SME, gender, and quality. Look, let me now invite Shakir. Shakir Merali is a very well-known and respected and seasoned professional in the private equity and finance space on the continent. Shakir is qualified from the illustrious London School of Economics, LSE, before building up his career with organizations like Aureus Capital, Abraj Group, where I met him and enjoyed dealing with him. Thank you, Shakir. I must acknowledge the work we did together there. He's now a partner at LGT Impact, focused on making a difference on the continent. And healthcare is one such area that Shakir is very passionate about. Shakir, I invite you to talk to us about LGT Capital and what you've noticed as the trend in the healthcare sector on the continent. Welcome, Shakir.
Thanks, Amit. And well, but for everybody else on the call, we've been working on the challenges around healthcare for many years. I think we first started talking about our famous Project Uzima in 2008, I think it was, where the plan to try and build this consolidated Pan-African healthcare services group was
initiated. And we must add, Uzima is a Swahili word that means wellness linked with financing. Yes. Okay.
Correct. So, in many ways, it kind of worked out. The group that Audrey was involved with, and I think some of the folks that I've seen her involved with is a reflection of that. Some of the work that started happening in North Africa was because of some of the ideas that we put together. Look, let me answer your question like this. We've been working on the healthcare space for many years. Obviously, there continues to be a substantive challenge, and it requires many stakeholders to get together to be able to try and address in the Africa space. And let's also be clear that it's not a fixed target; it's a moving target. We have a changing disease burden now. Obviously, this pandemic hit us from left field and has exposed, in many cases, a lot of the vulnerabilities that we face in various countries with regards to capacity and ability to deal with some of these problems. In Africa, to some degree, we've actually been helped by the fact that we've been combating pandemics of one sort or another for a few years, and you've seen some of the better responses in parts of West Africa and Central Africa. But in terms of the availability of resources, it remains an issue. So from a particular perspective, from our perspective, there remains systemic challenges to being able to avail quality healthcare to the populations in Africa, and particularly north of the Limpopo, north of South Africa. In the rest of sub-Saharan Africa, the challenge is particularly acute. South Africa also has its own unique issues, not least the fact that regulations and the extent to which government is engaged in healthcare changes some of the dynamics in a particular way, so that you can't apply some of the other healthcare solutions we're finding in Africa. But what is becoming evident to us and what we are looking to fund is the availability of the right kind of healthcare solutions that are Africanized, that deal with what is the African problem, that are not prescribed from abroad, that are not ivory tower based solutions, but solutions that are developed by people who actually operate on the coalface, on the ground, and realize that there has to be particular ways of dealing with some of the systemic challenges that we face. And what are these challenges? First and foremost, it's not actually a paucity of capital. It's not a lack of capital available for healthcare. Healthcare is a very attractive sector. It's a very defensible sector. There'll always be demand for healthcare. The problem is not a demand problem. The problem is a supply problem. And supply is not determined by fancy buildings and glistening equipment. It's actually determined by having the right caliber of people able to deliver healthcare. And that remains the fundamental problem. We simply don't have enough of the right kind of healthcare professionals. And consequently, the costs of delivering healthcare just rise because we don't have enough people like there might be in some of the other markets. And to complicate that further, where there is an outflow of professionals from Africa, in many cases it is healthcare professionals, which is why in the NHS in the UK, you might just as easily be treated by a Zambian nurse or a Kenyan doctor. So that means that we have to put capital behind solutions that deal with the problems that we face on the ground. And the majority of illnesses that people will face on the ground will tend to be at the secondary level, although we're starting to see complications that require tertiary and quaternary care. And that means that we need to be able to put our capital weight behind solutions that allow for task shifting to increase the scope of healthcare services from individuals that might not necessarily be considered full healthcare professionals in other markets, and where we are leveraging the use of technology. It's the only way we'll be able to build scale and be able to drive down prices in order to be able to to support what is just, a substantive growing burden. And then on top of that, all the solutions that you heard Kwasi and Audrey talk about with regards to availing information, trying to ensure that we've got the right kind of preventative mindset as well. And it's going to be a factor of all of these that will see us starting to move the needle or make some kind of dent in what is a massive wall of problems that we face on the continent. Thanks, Amit.
I think, Shakir, you touched on a very important point. We've got delegates now, I've been told, from 37 countries, and they've ranged from manufacturing to training to academia to those who are providing health services. You talked about the supply side challenge, and you were very spot on. In fact, if you look at $1 billion going from Nigeria every year on medical travel and tourism, they go and end up in countries like India and spend because they believe the skill and the supply side is higher. You also mentioned the brain drain, and Kwasi will tell you there are more Ghanaian doctors maybe in London and more Nigerian doctors in LA than they are in their own countries. That means it's probably even making it worse. So how do we deal with this? I'm going to come in reverse order. Some of the challenges that you mentioned, Audrey and Kwasi mentioned. I'll start with you, Shakir, and go in reverse order. How are we going to deploy capital to effectively to deal with such challenges? How are we going to guide as smart investors to ensure that the money is being spent in the right channels? And how is LGT Capital dealing with the supply side issue? I also want the attendees to hear how they can do business with you around the ticket size or the characteristics of the business. If I'm a manufacturer in Mombasa or a distributor of medicines in Nigeria, how can I contact LGT? What are you looking for on this continent? And what's your typical engagement style so that we can grow the business of health in Africa to deal with the supply issue that you mentioned? Shakir, over to you.
Okay, so I'll try and answer those questions in reverse order. So again, there are a few of you that actually do know me, and I've been involved in standard private equity, looking at healthcare for many years. I don't believe standard private equity is the right solution for dealing with the healthcare issues that we face today, because it's constrained by an external process of limited partners who've availed funds that require a certain return. Building up the right kind of effective healthcare systems is actually about leaning into developing a solution for a particular problem, and it means having capital that is truly patient, where you can weather what are going to be storms around innovation and challenges that you are likely to face. The most successful deal I ever invested in was actually a healthcare business, but that business was at very close points, and Audrey will know this, almost bankrupt. It required us to engage quite heavily to find the right kind of solution. Plenty of good learnings from something like that, but again, classical private equity that requires an investment with an exit outcome within 3 to 4 years is probably, in my opinion, the wrong kind of capital. And one of the reasons that I work with LGT right now, because we've got a fund that is off the balance sheet of our institution and therefore is long-term in nature. And our intention is to find opportunities that we can invest in that we can actually lean into and build true platforms over a period. How do we actually do that, and what is it that we're looking for? I think there's no way that one can find a comprehensive all-in-one solution to all the healthcare challenges that face us on the continent. It simply isn't possible. So, like everything else, one needs to break down the problem into somewhat more manageable parts and then try and find a solution that makes sense, at least to some degree, for the part that you're looking at. So to give you an example, if one considers the issue of ophthalmology and dealing with that as a particular care pathway. There are some very good examples from the likes of Arvind in India, where the ability to apply task shifting protocols, the ability to develop particular protocols allows for task shifting so that scarce doctor resources can be used for just critical procedures and allow for those critical procedures to happen in a rapid fashion and consequently reduce cost per time, and therefore the overall cost of providing this kind of care. So those are models that I think we can import, and certainly from our perspective, this is the sort of thing that we are looking to back, where within the scope of a particular care delivery area, you can actually develop a model that allows for efficiency and optimizes the use of resources. Another area might be, for example, maternity care. And again, this is where one needs to be careful, because on average, say about, 95% of cases, and Amit, you'll know the numbers better than me, but 95% of cases are regular cases. 5% have require an emergency intervention. By this, I mean, the likes of a C-section, and about, a quarter to a third of those are actually, very complicated. In order to avail, quality maternity cases quality maternity care to deal with 95% of the cases, one doesn't necessarily need a super specialist OBGYN. One can use, in some of our markets, a clinical officer. But then, one needs to have protocols to deal with emergency cases when they arise. And because of the markets that one might be looking to target, in particular, lower middle income areas, that basically means that, in high density urban areas, for example, Nairobi, setting up this kind of care that will allow you to deal with the majority of the patients with lower cost but effectively trained specialized health workers might expose some people to risk, because taking someone from a little maternity, specialist maternity clinic to a hospital that is a couple of kilometers away in Nairobi traffic during non-COVID times, even though it's an ambulance with flashing lights, doesn't necessarily mean you're going to get to that hospital faster. And consequently, the risk of mortality in those situations is higher. Sure. However, one needs to balance some of these risks to be able to develop the right kind of system. And so again, I mentioned this with the notion of we're looking at trying to find the right kind of healthcare delivery systems that are holistic in their mindset and address the key fundamental challenges we have, which is in many cases the lack of qualified supply in terms of healthcare professionals. I'll just make one final point before handing back to you, sorry, Amit. There's a big space for technology to play a role. There are certain markets where there are many healthcare professionals. One of the problems we have with, for example, the fact that in Kenya we had a massive government investment in a whole bunch of imaging capacity that's scattered across all the counties in the country, but can't be used is radiological capacity to be able to read those images. And that's the sort of space where technology can play a role. And again, that then requires the right kind of interface with government and, allowing the right kind of regulations for this sort of thing to happen. But that's another area where I'm of the view that applying the right kind of mindset and being specific around the solution you're trying to avail and the problem you're trying to solve can lead to truly African healthcare investment opportunities.
Thanks. I think, yeah, thank you, Shakir, for that intervention. I'm coming to you, Audrey. But Shakir, 3% of the global human resources for health are in Africa, and we are dealing with 16%. This data has been stagnant for 10 years, and it may skew. So task shifting, you can talk about it, but telemedicine and innovation, we may not be able to build that many health workers for the growing population in Africa. So I think you're telling us that in addition to task shifting, an overlay of technology, so we have a multiplier effect across the continent, which reduces the traditional healers and other kind of practitioners who may not be qualified providing care in Africa, which is another big issue that we are continuously going to face, especially in remote areas. Any comments on that?
Yeah, I mean, I think it behooves us, and again, it's unfortunately a function of the governments that operate over here, but it's necessary for the right kind of investment in building up the human resource. I think the traditional models of medical resource is part of the problem because it takes so long for people to be qualified.
Yeah.
I think to some degree we've addressed that in Africa. I mean, the notion of clinical offices, for example, is something that's relatively unique to Africa. I don't see that. You get nurse practitioners in the UK and some of the developed markets, but it's not like they can prescribe 70-80% of a national formulary like CEOs can over here. So I think there has to be more investment around that, and there have to be more models that can find and recruit these kind of people. So I wouldn't necessarily toss the traditional healing completely out of the window. I think that certainly when I've walked around with the Maasai and learned about some of the medicines that they use for traditional healing, a lot of it is actually quite efficient. I think there's a fair amount that we can learn, but I know that there are certainly the guys that put up little signs on telephone poles suggesting that they can heal AIDS and broken hearts at the same time might not necessarily fall within the same qualification of good healthcare in Africa.
Sure. Talking about poles and broken hearts, and Audrey might find that not a qualifying criteria for the pillars that you talked about. Audrey, over to you. Tell us a little bit about the size of the new fund. What year are you looking for? What do you see is a message to the attendees who want to engage with Sweat Fund in a focused manner that you mentioned earlier? And talk to us about the characteristics of the clientele that you seem to be excited in the next few years about.
Okay. So when you say size of the new fund, we would want to, invest anything from $30, $40, $50 million a year in healthcare. This year has been a very slow year, so we're not even going to get close to our target. Last year wasn't so bad. And I think the reason we cannot reach, those targets, and especially in Africa, in Asia, we see a lot of opportunities, but we do want to do more of our investments in Africa than in Asia. So finding investments that can scale and that can take that size of investment. We're financial minority investors. So, typically we wouldn't want to take stakes of more than 20, 25%. That's a quarter. So if I'm saying, $10 million on an investment and I'm, 25% shareholder, we're talking of a company that then would be $40 million valuation size. And there are not very many companies, that are $40 million. So what has tended to happen is, the opportunities we find are there are existing companies and then it's incremental growth. So they will, take some capital and increase what they're doing. But then greenfield opportunities, whilst they're there, the structure sometimes might not be strong enough. And for us, because again, we're financial minority investors, we're not specialists. We have a very small team. So we need to find either funds or institutions, companies that are investing in healthcare that exist in that market and have experience. And that is a bit of a challenge for us because and some of the projects that we see that are greenfield would not have that experience around the table. So we would want to either have operators coming in, and again, operators from Europe don't want to come into Africa. The returns are not attractive to them. Maybe from India and Asia, they might want to come into Africa. But again, sometimes the structure of how they want to be remunerated might not really align 100% well in terms of risk sharing. So because of that, finding those opportunities at the size that we want becomes challenging, and so we tend to then look at smaller tickets. And I think maybe one other challenge in this market that probably would be discussed further by the other panelists is the issue of affordability of healthcare. The financing of access to care. So many times you find we will make investments, and when we look at financial viability, wanting investments that can generate enough cash flows to run themselves, then you find your pool becomes even limited because you're looking at companies that are serving the middle income or the mid to high income groups. And we want to reach the low and middle income groups. But then now finding those models that are scalable, they're not very many. They're not many, and then some of them are very early stage. You're still not sure if they will reach scale to become EBITDA positive, for the non-financial people, a point where they can cover their costs and have some money left over for growth. And then because we are financial minority, we work a lot also with private equity funds, but as Shakira has mentioned, PE funds are looking at deals that they can turn over in 3 to 5 years. So again, that limits the pool of investments they would look at. They would not build a new hospital. It's very rare that you find a private equity fund, entering a hospital project, because construction alone is 3 years, and then ramping up is 3 years or 4 years, and then you don't know what shocks will come along the way. So, you need to probably take a 7 to 10 year view on construction of a hospital, or a factory maybe might be shorter. But if you're looking at new additional bed capacity, a new hospital, you will not find many PE funds looking to do that. So again, that poses a challenge for us. So in terms of maybe a message to the attendees, what we're looking for investments that we can scale. So it could mean existing institutions working together, so instead of having 3 doctors running their own clinics, why don't they come together and put up something that is then attractive capital that wants to look at investments that are of scale. So maybe I'll leave it at that point.
No, I think it's very clear. And I think you've also, I think the music to the ears of the attendees is you're looking at growing in Africa. You've seen it in Asia. You're actually urging the entrepreneurs here to think innovatively about group practice. You're also trying to encourage the innovators to show a certain standard that shows scaling up, but with something in mind that eventually firms like yours will exit. So they would have to use the capital smartly in order for them to grow and enable them move to the next level. But size matters. And so talking about that, let me jump to MCF. And what Kwasi has done, he's tried to break it down into smaller pieces. And so I think MCF is trying to be more, I would say, budget friendly. And you have a different way of looking at financing this also compared to the traditional fund. So Kwasi, what have you seen, and how some people think it's very risky to break it into a small size, and you'll have non-payments and you'll have huge debts, and you do the same amount of work when you want to deploy, say, $1 million to $10 million. How is it going from your group in trying to help more of the on-the-ground facilities. Over to you, Kwasi.
Yeah, thanks, Amit. So no, you're certainly right. Doing the due diligence for a maternity home might even cost you more time than doing it for an established facility. And because the established facility may have the processes in order, whilst a maternity home doesn't. So it's quite a lot of work. But I think the motivation is, what is the problem that we're trying to solve? And so I can understand that, we have, if you look at the population of Africa, about 70% of the people don't have access to decent care, the informal sector. And of course, you have people who will go to London and to India, but even some of the poor people will go to India. So if you had a kidney problem, Ghanaians, they go to India often. So it's good that we have a range of panelists here looking at the broader spectrum of health financing. And of course, within Farm Access, not really within Farm Access, but Farm Access collaborates also with the Investment Fund for Health in Africa, which deals with equity, and invest heavily. But coming back to MCF, it's a lot of work, but it's the mandate. And so, like I said in the beginning, if you look at the way that we've done it, we now have over $95 million disbursed. And this is going to over 2,000 clinics. So, so you can see the variety moving from maternity homes to dispensers, to pharmacy shops, to primary healthcare centers, to hospitals and distributors. So it's a whole range of it. And I think the success, you can attribute it to a dedicated team that we have also in the country. The model until now has been partnering with local banks. So in all the countries, we had that partnership with local banks, because the local banks have the channels to distribute the loans. MCF in the beginning, when it started, was actually taking all the risks, because the banks felt that, healthcare is something, particularly when you talk about the bottom of the pyramid, the low and medium healthcare facilities, they want to just stay out of it. So, MCF took all the risk. But, last year or so, we have like equal risk participation, where the banks actually saw that what they were doing with MCF was actually the best performing portfolio that they had. And because if you're a bank and you're lending to small and medium-sized facilities, and you have a repayment rate of 97%, which is due to the dedication of the team, the due diligence they do, the training that goes with it. So it's not just a matter of somebody appearing and saying, I need a loan, and that person gets a loan. So the track record is there. But of course, working with the banks, there are always challenges. And so getting into the future, and I think Shakira and Audrey both mentioned the technology. How can you leverage technology to deliver the loans in a much more efficient way? So in Kenya, MCF has started digital lending, where because facilities are using MTIBA or M-Pesa, you can have insights into their turnover. And so when they come to you, you are not going to require a collateral. That's been one of the challenges that the small and medium-sized facilities have faced. They go to a bank, and then the bank says, I need a collateral, and the collateral may be 10 times the loan that they need. So, but, using technology and having the insight into their turnover, you can give them loans because you know that they're doing, cash flow, they're doing something profitable. So that is something that MCF has leveraged upon in Kenya, and they are extending it to other countries. For MCF, I can say that money to disburse is not the issue. And so all those listening, if you have a very good business and you want to engage, the money is not the issue. The issue is finding a very good business to invest in and making sure that you have a credible partner, be it the business owner or the healthcare provider, willing to work with you to deliver on that. Is one of the things that MCF also did during the COVID. We are still in COVID-19 period, but in the initial stages, we know that in Africa, fortunately, the impact of COVID-19 on the health of people is lesser than when you compare to Europe. Not many people are dying. Many people don't show symptoms, but the impact of the economy is massive. And that is something that we want to address, or we have to address. So what MCF has done, and I don't know whether others have followed suit, is sort of giving flexible lending.
Okay.
Taking into consideration the fact that we are in challenging times, and really seeing how you can help the facility come out of that challenge and be able to move the business forward. So that's so once again is the mandate to make sure that over 70% of the people who don't have access to care get access to care, and that we have to focus on a wide range of facilities. And so we can give, when we started, the loan was very small. You could give like $2,500. But now we have the mandate from the investors to give up to $2.5 million.
Okay.
And so there's money to support healthcare facilities. The challenge is that, we got to identify those businesses, and that's already been said, make sure that those facilities, they also do what they have to do, because sometimes, although we are still in the digital era, you still need to provide certain documentation, to support your business.
Sure. Thanks, Kwasi. I mean, this really provides you just a snapshot of what Audrey does, what Shakir does, Swedfund, LGT Capital, and also what MCF does. It also shows you the different sizes of funds that they're interested in and in the structure of engagement. What this tells you to all the attendees that there are choices. And I think that's the biggest thing, the mindset that there are choices on how to expand your business and so that you can grow effectively is not the traditional banking side. I thought you brought the banking side well. I mean, banks have been a great partner for many of the businesses. I know bankers are here. They've logged in. I want to thank them for joining in. But maybe the banks don't understand healthcare as well as what you did. And Kwasi, what you started saying is you became the friendly intermediary who then did the due diligence in not the traditional energy and the agriculture way, but in the healthcare side, making sure that the funds cycle in an appropriate manner. So I think that's really good. In my next slide, I'm going to jump onto questions, and I'm going to start with a question for Shakir. But I think your insights, all three of you, have been very robust. And I think the message to everyone who's attending is there are several models. Giving up on some great idea that you may have started is not necessarily useful, because today's webinar is to just give you a flavor. And there are many more people who are out there who are doing very many wonderful things in healthcare financing. And some of you who've logged in are looking for new partners, and you're looking at new links. You could be a business owner, you could be a specialist, you could be a financier. And that's what AHB specializes in. We become the nucleus on making sure that the growth of the business is responsible in Africa and effective. So Shakir, there's a question here that's coming from Divine Akaba from Ghana. What is the right model for healthcare financing in sub-Saharan Africa? And where are some of these models and examples we talked about Uzima and everything. What comes to your mind? There may not be one answer. Over to you. What do you think?
Yeah, so I think I attempted to answer that previously. There is no one solution, right? It's all around what particular issue or problem is it that you're trying to deal with. There is financing that comes from government. There's financing that comes from NGOs looking to achieve specific outcomes. There's financing that comes from investors like Swed Fund or investors like LGT. And then there's financing around specific programs like some of the ones that Kwasi spoke about. At the end of the day, if you ask me, it's a simple answer. The financing that backs a solution and actually moves the needle to some degree is the right kind of financing. So it really depends on the challenge. It really depends on the problem.
Can I add to this?
Yeah, of course, Kwasi.
Yeah.
Feel free.
So I think here we got to distinguish between two things. One is, I'm not in the, one in the mind of the person who asked the question, but I think there is the financing of the services themselves, and then you have the investment to make it work. So when and I think Shakil refers to the investment to make it work. So then that will be, all the things that we have spoken about, and even there you could talk about. It's not just always saying it's equity or lending. It can sometimes be blended financing, and particularly when you get into a setting where, in a context where you actually don't know what to do. And then you are equity fund, what do you do that? Can you take the risk? So in that case, it helps also if you can partner with an entity that will take like the first loss. And so that you can deploy your money in a way that will give you the return. And so I think that's important. This first point is the financing of health itself in the sense of the services. I have a preference for insurance. Yeah, because we've seen, Ghana is an example where since 2003, they have health insurance funded by tax. And now 11 million people are in the program and enjoying access to services. And because they have tax, VAT, they are able to also even exempt some people from paying any premium, pregnant women, children, older people, disabled people. So the beauty of it is that it's a risk pool.
Yeah.
Yeah, and for me, that would be my preference. Of course, donors go in and then they finance specific initiative. Like the Global Fund is doing, which is very important, because if you look at how to address HIV, TB, and malaria, they need a focused attention. But if you really want to achieve universal health coverage, it's important that you look at how you can integrate these vertical programs into a more primary healthcare services. That's what I want to add.
Very well put. And I think talking about Ghana, Audrey, what divides us? Is it language? Why we're putting more money in East Africa to West Africa? What's the story? Is it true? Is it true, and why, if it is?
It is true, and that I think if you look at and I Bijou is not here, but if we look at IFC's portfolio, being one of the largest investors in healthcare, you'll see that they've done more in East Africa than in West Africa. And they have teams in West Africa. We don't have a team in West Africa, so maybe we could say that's the reason why we haven't been as active in West Africa. But then I think the fragmentation comes in, because if you're looking at investors who want to invest $5 million, how many opportunities are there? Maybe there could be a number of doctors or clinics, but then are they standalone to take 5 million? So you probably will see somewhere investors or PE funds have tried to put together some assets to sort of make a group or a platform, then you can put in $30, $40 million. I think also it's easier to invest in East Africa than in West Africa, but maybe that is changing now. And I think East Africa saw a lot of private equity funds come in, over 10, 15 years ago. And, Shakir can tell you about that. They were among the first PE funds on the ground. So, of course, I think it took off a lot easier here than in West Africa. Boots on the ground makes a difference as well. And so I think as funds look to set up shop in those countries as well, then we'll see more activity. For Swedfund, we still don't have an in West Africa, so that has limited our view of the market. We do want to partner with funds in that region, and we've been in touch with some of them to see how can we work together, what opportunities are there for investment in West Africa, because we want to increase access to healthcare services for all Africans, not just East Africans specifically. So I think West Africa shouldn't worry. If there's any people from West Africa here, I think you will see more attention coming your way, Kwasi and co. So, but we do need to see scale. So scale the businesses and the opportunities. And if I can go back maybe to what Kwasi said about insurance,
yes.
What Shakir said about, it's not a supply issue. A lot of investors are interested in investing in healthcare in Africa. Time I was talking to a fund out of France, and they were looking for projects, 2,000 bed hospitals. And I asked him, in Africa? And he said, yeah, and I said, that is too large. We don't see, private enterprises with a 2,000 bed hospital. Maybe it could be a number of hospitals in a number of countries, but just one 2,000 bed hospital, we don't see that. And I think the challenge is because even if you build that 2,000 bed hospital, how many people will actually come and seek services there? How many would be able to afford outside of if, private insurance only touches a limited number of people. I think in Kenya, is it 3% or something? Have private healthcare insurance, or maybe even it's smaller. The national schemes cover a lot more people. But then the national schemes also, what are they buying? What are they buying from providers? Are they going to expand the cover like the way in Kenya, at least, kidney treatments, and kidney dialysis? The national insurance started to buy services from the private sector, which increased access for people because the public hospitals were constrained and couldn't see all these patients. Sometimes machine would break down. You can imagine for 2 weeks, that's the only dialysis machine and no one can access treatment. So by opening up and also purchasing from the private sector, more people were able to access. So I think if we see a deepening of insurance, that part of mobilizing, accumulating financing for healthcare, for people to purchase healthcare services, then we'll see on the supply side also a lot more investors looking to expand because the demand has increased.
Excellent. Thanks. You talk about appetite there and $5 million and plus. Kwasi, West Africa appetite, can they absorb this? I'm hearing that also for you, where the fund is smaller, do you notice the same trend where MCF absorption in East Africa seems to be more than West Africa? And what is your reasoning?
I think there's appetite everywhere for financing. Let us not forget that the largest market is in Nigeria. It's not in Nairobi. So I don't want to make this West Africa, East Africa fight.
Yes.
But if you look at the population, the largest market is in West Africa, at least, Nigeria. So there is appetite, but of course the economic hardships, and then we have COVID-19 and all the challenges that they bring. So whether it's borrowing or investing, a provider needs some perspective. And I think that is something that is actually impacting or will impact the market this year and the year before. So you also need collaboration. I think it's not only from MCF and Swedfund and others. But also at the national level, you need sound economic policies to make sure that any investment that you make will make sense. And I think with that respect, I think Ghana, for example, is doing quite well. Yeah, so I really see the need also for stress fund to go there. But for MCF, like I said, the funds are there. It's more, and MCF is going to a new phase of, leveraging technology to make the delivery more efficient. It started very well in Kenya for obvious reasons, because M-Pesa and others are there. So so once again, there's no distinction between the two areas. Demand is there, and where there's demand, you got to capitalize on it.
Kwasi, your question is about technology and cost. You interconnected the two, but very briefly, what do you see is the best and the smartest way we can leverage technology that will reduce cost of healthcare?
Yeah, so I had the discussion around, I think Shakil talked about e-health, and maybe Audrey also. So, that kind of initiatives are important because one of the things that I say is, why should a poor woman in a village in Nigeria travel 20 kilometers to a hospital only to hear that the doctor is not there?
Mm-hmm.
Yeah, so it's a basic example of how you can use technology, and that lady or man will get the information before it goes to the hospital. So the e-health in that sense, and if you look at some of the, it's coming up in Africa and with a lot of apps and etc. But I think it's particularly developed more in the US, where if you look like WebMD, Healthline, they are billion-dollar companies, and they are providing services through telephone to people. So Pharmaccess, on our part, we're also working along that lines, trying to ensure how we can leverage technology to provide health information, advice, and counseling. So that's there. But I think the fundamental point is, how do you use technology to make the delivery of services efficient? Yeah. Okay. Yeah. Okay. So and that is, so how do you use technology to make the financing and the delivery efficient?
Efficient.
Yeah.
Mm-hmm.
Yeah. So when we look at the financing part, technology plays a very important role. Until now, the technology that we talk about in healthcare has always been on how do you use technology to do, better surgical practice. How do you use it in informing people? How do you use it in making sure that a pregnant woman will not miss appointment? What we haven't spoken a lot about is, how do you use technology to mobilize financing for health? Yeah. Mm-hmm. So we, again, working with CarePay, Kenya is an example where we have developed what we call mobile health wallet. Right. And so instead of you have your normal wallet and it's in your pocket and you have the credit cards in it, we have developed here a mobile wallet that is on your phone. So what it helps you to do is that you can actually save for health. Yeah. And because normally, even if you want insurance, the premium is not something that you can pay one-off. One of the reasons why the telcos have been successful is that even if you have maybe 10 shillings, you can buy units. But whenever you need insurance, then they are talking to you about $100. How do you get it?
Exactly.
So, yeah, so being able to save and pay for it at the right time is important.
Sure.
And that mobile health wallet can help you do that. With the mobile health wallet, it can also help you receive entitlements from different sources. The point that I made about, donors doing all these vertical programs for one individual, that individual can actually mobilize all these resources into the mobile wallet, that when the person goes to the hospital knows that, hey, okay, you have malaria, but you are pregnant, so why do we just say this is USAID funded it and this is DFID? Yeah, so the mobile health wallet will help you to do that. We are also at the farm access leveraging this technology to mobilize remittances for health. Donor funding is going down, but remittances are going up. So how can you ensure that a Nigerian in Houston will be able to pay for insurance for a relative in Lagos? Yeah, without going through any bureaucracy. And so we're working on it called Health Connect. And that is so I can talk about all these things from the financing part.
Yeah.
And end that up with collaboration that we have with the Global Fund. Where we are going to integrate HIV/AIDS financing in an insurance scheme. And then see how that can be done. So that is the aspect of the financing, and of course the delivery side. We have safe care assessments, which and support, which have been digitized, such that and it brings the cost down.
Right.
We have an initiative that we call Mom Care.
Right.
Which is really supporting better delivery of care to pregnant women, because then you cut down complications, you promote safe delivery, and all these things are linked to performance. So if the provider doesn't deliver, there's no payment. So those are some of the examples that I can emphasize now.
Thank you, Kwasi, so much. As usual, we run out of time on conversations like this that are interesting. I want to thank all the questions, people who have written down their questions. Some of them will respond to you later on email, but from South Sudan, from USA, I would like to thank Victoria Shombo. I'd like to thank John Masasabi, Sophie Githinji, Mabel Nangami. Some very interesting questions are coming through. We're running out of time. But what's also very interesting is for Shakir, Audrey, and Kwasi, people are asking if you're interested in funding X kind of hospital in Ghana, X kind of factory in Mombasa, and so on and so forth. So the message is that this is the hub. Africa Health Business is actually the magnet that provides the linkage of people who want to grow the business of health in Africa. Send in your requests. This is why we organize this webinar. It's literally to connect, to ensure that we get responsible growth of the healthcare business across Africa, whether it's size. If you do want to contact the panelists directly, you're also welcome to. But at this point, obviously, I want to get to the parting shots from our panelists. I will give one parting shot on behalf of Shakir. I'll take that spot because he had to unfortunately go for a he had to go for a meeting, but I'll address 2 or 3 points on public-private partnership and universal health coverage. But I want to start with Kwasi as we wind up your parting shots, and then Audrey. So Kwasi, just a minute of your parting shot, then I go to Audrey.
Yes, thanks a lot for organizing this webinar and to enable us to share our perspectives. So what I want people to think about are 2 things. One is that 10% of the GDP transactions in Africa is done through the mobile phone, mobile payments. And that is compared to 2% in Europe and the US. So Africa is way ahead of the rest of the world. And the point is that we can use mobile technology to revolutionize healthcare, make sure that 70% of the people who don't have access to care will get access to care. The second point is, why is it that we are spending on average $85 per person? Total health expenditure is $85 per person per annum in Africa. Whilst according to global estimates and the WHO, if you spend like 60 to 90, you should be able to cover people with care. But we are still in a continent where a lot of people don't have care. Insurance, I believe, can help address some of those challenges. Thanks.
Thank you, Kwasi. Spot on. Audrey, parting shots from you.
SWAT Fund and other investors are committed to supporting healthcare in Africa and Asia. And, healthcare is a key part of the economy. If we're not healthy, it's going to be a challenge for development. And so, as also Kwasi says, risk pooling is really important. Insurance, within, there are many people represented on these calls. How can we as Africans increase the amount of money that we save towards healthcare? I'm not even talking about we as investors, but now I'm talking as an African woman, a mother, a daughter. How can we increase the amount of money that our governments put towards healthcare? How can we lobby them to put more taxes towards healthcare? How can we lobby ourselves to save towards healthcare? In the countries like Kenya and Ghana, where you have a national health insurance scheme, are you a member of that scheme? Are you contributing? Because I think that's the first step, and then demanding that these institutions then pay for healthcare for us Africans. And in doing so, then, with investors looking to support the healthcare delivery, I think we'll see more access for people to quality healthcare in Africa. And, if you have a project you think that might be interesting for SWAT Fund, our contacts are on our website. Feel free to drop us a line.
Thank you so much, Audrey. Thank you, Kwasi and Audrey, for your time. I would just like to say that we do need more money for healthcare, but we need more healthcare for the money. So everyone on this webinar, we need to hold leaders, both in public and private, accountable. So we stop seeing graft and waste, whether it's in procurement, service delivery, because we could multiply the number of women and children that could have received healthcare by twice if we just had a simple monitoring and evaluation and ethical practices in healthcare, where COVID-19 funds that have been raised don't get actually chewed up by numbers that we find very disgusting in the continent. So together we have a responsibility, no matter which country we are in. And in this pandemic, it has been shown that whether you are from the Western world, a developed country, mid-sized country, or Africa, we are all in the same boat. I think literally when it comes to stress, the amount of taxpayers' money that's wasted is horrendous. And that equals to loss of lives. So I believe that through public-private partnership, we need to hold each other accountable. We need to build a better trust between public and private. And that's done through dialogue and advocacy. We believe that three key areas need to start focusing on. One is the financing. Both taxpayer funds and private investments are the answer. So we should increase what we can. The other is servicing. We should become very innovative in the way we take services out to the people on the continent. So we need to look at innovation, telemedicine. Let's take healthcare closer to the people and make the geographical barrier disappear. And thirdly, is a topic that came out today, which we need to speak about, is develop the human resources for health training and academia. It's been an area that the public sector has dominated and controlled for reasons that we all know. That's about quality, but I think the private sector can scale up and we can bring the health workforce of tomorrow. So fit for purpose workforce that will treat the next generation in a cost-effective quality care that will enable Africa move to the Africa we want. At this point, I want to thank all the attendees and want to invite the head of MedTech and Healthcare at Africa Health Business, Kaushal Shah, who's put a lot of work behind this, to take it over from here and tell us about the next webinar and some offering that AHP will have. Once again, thank you. Kaushal, over to you.
Thank you, Amit, for taking us through the healthcare session. That was very interesting. And also thank you to all the speakers. It was a great pleasure to listen to your views and to learn about what you actually do. I learned a lot today. I'm sure so did everybody else listening in. So on the topic of healthcare financing and knowledge sharing, and in line with Africa Health Business's goal, which is to improve access to equitable healthcare in Africa, today I'd like to raise awareness of a fantastic course that has been put together by Last Mile Health. Last Mile Health is an organization that is working to improve access to quality essential healthcare for people living in rural and remote communities. One of its global initiatives is a community health academy. This was launched in 2017 to revolutionize training for community health workers and health system leaders. And in particular, I'd like to draw attention to a specific course created by the Academy, that is the Financing Community Health Programs for Scale and Sustainability course. The title itself highlights how important this is for us. So the course presents an in-depth exploration of the financing value chain required to understand resource needs, as well as to mobilize resources for community health. And it aims to engage learners with insights from various stakeholders, such as ministries of health, ministries of finance, global health institutions, private sector organizations, and academia. The course also looks at how different financing approaches have been implemented in practice, something that we spoke about earlier in the webinar. In fact, Dr. Amit Thakur was a part of the impressive faculty that has actually taught the course. This valuable course is free, so everybody please spread the word. So on behalf of Africa Healthcare Business, I want to extend a special thank you to our event partners who made this webinar possible. I'd also like to highlight that next Thursday at 4 p.m. East Africa time, we'll be hosting the third thematic session in our webinar series of Partnerships for Resilient Health Systems. The session next week will be on the topic of manufacturing and supply chain. So if you haven't, please do register and hop on and join us next week as well. And lastly, if you are interested in learning more about Africa Health Business and our services and partnering with us, I saw actually a lot of questions about us as well today. So please feel free to reach out to me using the details on the screen. Thank you for joining us today, and see you next week.
Bye, everyone. Thank you, Kwasi.
Right. Yeah, thanks.
Thank you.